Good evening, everybody. Welcome to this evening episode of Pursue. And today we are starting with Pursue 10. And today we have Pursue 10A, which is breast pathology. And we are streaming live from Government Medical College and Hospital Chandigarh via Kolkata. And today we have Dr. Pavithra H N. She is an MD pathology from PGI Chandigarh. And presently she is a demonstrator in GMCH Chandigarh with multiple publications in national and international journals. Her area of interest is breast pathology, and she'll be talking today on benign lesions, fibro-epithelial lesions of the breast. Before I ask her to start, let me request all of you to please keep your mic muted, your camera off, and please do not share your screen. When you log in by join now and don't present your screen. With this, let me request Dr. Pavithra, ma'am, please share your screen and start. Thank you so much. Please press present now.
Thank you, sir.
And your entire screen. And then press on the center of the screen and share. Yes, I can see your screen coming. Very nice. Please make it full screen. Yeah, that's right. Just make it full screen, please. Yeah.
Okay. Is it visible, sir?
Absolutely fine. Yes. Let's come to the first slide. Is this the first slide?
Okay. Yes, sir. This is the first slide. Thank you so much, sir.
Right,
So for the students, today we are talking about the breast pathology. So as you all know, that is the mammary gland, composed of skin, subcutaneous tissue, and the deeper functional glandular tissue. So this rests on the pectoralis muscle, and that is separated by the pectoralis fascia. So to start with the normal histology of the breast, so it is divided into 15 to 25 lobes, which are made up of around 20 to 40 lobules. So the secretion starts from the TDLUs, that is a short term for terminal duct lobular units. So from the TDLUs, the secretions are drained via the intralobular tubular ducts, terminal ducts, and the extralobular terminal ducts. So through this, they go through the ducts, and the ducts can be further divided into the subsegmental ducts. These subsegmental ducts, they join to form the segmental ducts, and further they form the lactiferous sinus, which is a dilatation, and finally they pour into through the exterior through the collecting ducts. So the collecting ducts, lactiferous ducts, and the segmental ducts, these are the larger ducts. And the functional units of the breast are the terminal duct lobular units and the large duct system. So the terminal duct lobular units, they are the distinct lobular architecture of the breast, and they form the functional units. So they have, so in this picture you can see this is a picture of a terminal duct lobular units. They have a specialized loose stroma in between, which is actually composed of abundant mucopolysaccharide substance. So they give myxoid appearance, and they are responsive to the hormones. And the area on the surrounding breast, they have the abundant elastic fibers, which is lacking in the terminal duct lobular units. And the entire ductal lobular system of the breast, it is lined with the specialized inner epithelial cell layer with secretory and absorptive functions. So we have one internal or inner the epithelial layer, and the other one is the myoepithelial layer, which is on the outer side. So outer myoepithelial layer, that will be discontinuous, and the inner ones are the epithelial layer, which is composed of either cuboidal or columnar cells. They are cuboidal in the collecting ducts, in the lobular acini, and they are columnar in the collecting ducts. So other than morphology, we use IHC markers also to identify them. So in case of some malignancies, so at times to distinguish the benign from malignant, we'll need some IHC markers also. The epithelial markers are the epithelial membrane antigen, mammoglobin, GCDF15, that is the gross cystic disease fluid protein 15, and GATA3. The myoepithelial markers are high molecular weight cytokeratin, smooth muscle actin, calpanin, smooth muscle myosin heavy chain, maspin, caldesmon, P63, P75 neurotrophin receptors. Also, we can use GFAP also at times. They also highlight these myoepithelial cells. So after the histology, we'll move on to the pathological part. So that was a short histology. So in the pathology, we'll discuss about the inflammatory or benign conditions today. So after this inflammatory condition, we move on to the fibrocystic diseases, adenosis, then the fibroepithelial lesions. So to start with the fat necrosis, that is a thing which we come across in the breast commonly. Also, most of the time, patient would not give any relevant history when you ask for. There may be these may occur secondary to the small event in the duct ectasia or trauma, or it may be occurring as a consequence of surgery or radiation therapy. So frequently seen in women with a large heavy breast or overweight women. They present as a superficial painless mass. The skin may be thickened, most often in the subareolar perioral regions, and but they can affect any area. So they'll be usually form relatively circumscribed lesions. And on MRI, they have a characteristic feature of black hole sign. The radiologist use this. And on gross, they may present as hemorrhage in the indurated fat initially. Later on, as the disease progresses, they may give a distinct yellow-gray color or focally reddish or tumor-like features. And they also can undergo degeneration or calcification. A microscopy, there may be disruption of the fat. There may be the abundant inflammatory infiltrate composed of histiocytes. Like here we can see histiocytes, lymphocytes, plasma cell, and all. They can be hemocyatin-laden macrophages, and on long-standing cases, they can also undergo dystrophic calcification. Further, there may be central necrotic fat with cavity formation, and they may be surrounded by fibrosis. So, only treatment for this is excision. The next entity is the fibrocystic changes. That is a benign alteration in the breast consisting of cystically dilated intralobular glands. There will be dilatation of the TDLUs. Their surrounding area may show stromal fibrosis or not. So it is actually the collective description terminology used for both proliferative and non-proliferative changes in the breast, and they are showing a hormonal imbalance with most common with the excess of the estrogen. The non-proliferative changes composed of cysts, apocrine metaplasia, fibrosis, calcification, and chronic inflammation. So the cyst can be either microscopic or gross feature. They usually are fluid or cloudy fluid, and some of the cysts have bluish scars, or that is also called as blue dome cysts. They are called so because they have seen that most of the cysts in the breast they contain fluid which is bluish in tinge, bluish in color, or they give bluish tinge, though the intensity of the color may vary. So that's how they got that blue dome cyst or bluish cast terminology. And the epithelial lining of most cysts, they'll be either flattened or you don't find the epithelial lining in the larger cyst. And another common change is the apocrine metaplasia. So it can be seen either in the normal lobules or in the dilated cyst. So I'll show you the apocrine change along with the pictures. I'll explain it. And they may show PS positivity in the form of crescent of coarse glycolipid granules, which you can on the luminal secretion, which are ejected out. So that may further lead to fibrosis, and further it can progress to hyalinization. Calcification can be in the form of either calcium oxalates or calcium phosphates. You may see crystals of these. Calcium oxalate crystals can also be bifringent easily. It is actually difficult to identify an HNE. So you can use bifringents easily. And other one is chronic inflammation. So as I said, the cyst ruptures that lead to the secretions which is released into the stroma. So this will attract the inflammatory infiltrates. And this is just a gross picture to show some enlarged cysts which are visible grossly. And the rest of the breast parenchyma looks unremarkable. They can occur along with the duct ectasia also, which we will be discussing in a while. So this is one of the panel of microphotographs showing fibrocystic change. You can see a very large enlarged duct, and this few smaller ducts also, which are even these are enlarged. So, and some of these are showing the apocrine changes. So these are the closer view. We can see that the this is the lining of, which is showing the apocrine change. They are more pinkish in color, so that is eosinophilic. They have, if you on a closer look, you can see they have large eosinophilic granules, and they are mostly columnar cells and with apocrine snouts. So these which are coming out, falling off, these are the apocrine snouts, and they will be having a nice, beautiful round nuclei. Then plasma cell mastitis. So this is a form of periductal mastitis or duct ectasia with an intense plasma cell reaction to the secretions in the ducts. Patient gives usually relative recent history of pregnancy, and they may be having nipple discharge, nipple retraction, or edematous skin changes. They present with mass in the breast. It may be formed to hard mass, so mostly like inflammatory breast cancer type of lesions. They'll have ill-defined area with dilated ducts containing thick, creamy to yellowish secretions. Sometimes they call it as like comedonecrosis type. So on microscopy, you can see that they'll be having sheets of plasma cells which will be surrounding the ducts or lobules. They also can have some giant cells without granulomas with histologic reaction. And treatment for this is usually excision. So we spoke about the periductal mastitis. What is it? So this was introduced by Hagensen in 1951. So this is for the diffuse dilatation of the ducts. There are spontaneous intermittent nipple discharge will be there. Mostly they are usually clear, yellow, green, brown in color. They are not palpable. They don't have some palpable mass initially, but however in the later stages they progress to mass, and also they may involve the nipple leading to inversions, eversions and all. So blood will be there if you, even if not visible grossly, if the sample is tested, blood can be found out in around 50% of the cases. So it is a relatively common disease of extralobular ducts with irregular dilatation, periductal fibrosis and inflammation. So mostly they occur in the perimenopausal, postmenopausal women. They have serious bloody or pus-like discharge in 20% of them. And later stages, as I said, they may be having nipple retraction and all because of the fibrosis. So this is just a gross picture to show that multiple dilated thick-walled cyst may be seen. And this is probably the initial stage. So we are seeing multiple cysts and prominent ducts. They usually contain pasty or granular secretions like. So and microscopy, along with what I told, the cystically dilated and periductal lymphoplasmacytic infiltrate, there can be neutrophils, histiocytes, and irregular dilatation and obliteration of the ducts and periductal fibrosis. So the next entity is the granulomatous lobular mastitis. It's a granulomatous inflammation of the breast in absence of specific etiologic agent. Occurs in Paris women after pregnancy. So usually this occurs after pregnancy. Mostly it does not occur during pregnancy. Etiology is not known. If there is etiology, that cannot be called as granulomatous lobular mastitis. The other name for it is idiopathic granulomatous mastitis. So idiopathic is something which does not have any etiologic agent. So if you find etiologic agent, that would be the cause of this. So if you find AFP, that would be tubercular. So if like that. And though there is no cause known, OCPs are implicated in the cause of this. And on sonography, they can be multiple clustered contagious tubular hypoechoic lesions. They usually present as firm to hard palpable mass, grayish white to tan cut surface with faintly nodular appearance. So you see numerous lobulocentric granulomas on microscopy composed of epithelial histiocytes. There can be Langhans cells or foreign body giant cells, lymphocytes, plasma cells. And these granulomas tend to extend to the surrounding stroma, the other ducts and all. It may not be involving one single TDLU. And as the disease progresses, there will be confluent granulomas, and center of the abscess may have microcystic spaces. So this is one picture which I took from a book. This shows multiple granulomatous inflammations and multiple granuloma seen with abundant inflammatory infiltrate. So all these things will come under DDs, and you have to rule out all the other causes. Only then you can label it as idiopathic granulomatous mastitis. And the other entity is the lymphocytic mastitis or the diabetic mastopathy. So this is a chronic inflammation of the breast composed of mature lymphocytes occurring mostly in association with extramammary autoimmune diseases such as type 1 diabetes mellitus or Hashimoto's thyroiditis. So they have a heterogeneous parenchyma pattern, and they may also be formed to hard palpable mass homogeneous gray white cut surface. So microscopically you see a lobulocentric inflammation. Mostly these are B cell type, and there will be periductal perivascular pattern, collagenous stroma will be there, fibrosis, atrophy, like you see in the other lymphocyte diseases. And next, after all this inflammatory condition, we move on to adenosis. Adenosis and their types. So adenosis is a relative increase in the number of acinar units in the terminal duct lobular units. So they are the non-neoplastic entities. So non-neoplastic lobular proliferation will be occurring. They are mostly derived from the tubules and acini of the TDLUs. So they will be having two cell population. So in a breast, as I told you, there is myoepithelial and epithelial layer. So once the myoepithelial layer is lost, we think in most in terms of malignancies, except for very few conditions. So here both the layers will be there. Two cell population is epithelial, myoepithelial, both are there along with the intact basement membrane. So grossly, they may appear as well circumscribed nodule, gray or pale tan from homogeneous tissues. Cystic changes are usually not seen, and if calcification is there, they get gritty appearance on cutting gross specimens. That is all. So to start with the different types of adenosis, so let's start with the florid adenosis. Florid adenosis, as the name says, itself says it is most cellular type of adenosis. There will be hyperplasia of both epithelial and myoepithelial cells, and there is proliferation of ductules and lobular glands. So this will distort the architecture. There is complex proliferative pattern. So and lumen caliber will be constantly relatively constant. So why is it? So this happens because the adenosis, it is not like they are only proliferating. Along with proliferation, they are entwined upon themselves. So that is there is swirling and they entwine. So that gives the appearance of more number of cells, more number of ductules than they are actually. So that's how you see so many ductules and lobular glands in them, and they'll have usually flat epithelial cells surrounded by myepithelial cells. So this is two photo micrographs of a case of florid adenosis. So you can see there are too many ductules and glands surrounding here, and they have some secretions also in them. So they, if you use a pH stain, they'll be positive. So inner layer is the myoepithelial one, epithelial layer, and the outer one. So at places you can see the paler. So those are the myoepithelial cells. And the other one is sclerosing adenosis. So this is one of the most common forms of adenosis, where there will be lobulocentric proliferation of the benign glandular structures. They are distorted mostly by fibrosis. So main thing is in this adenosis, there will be proliferation of glands. Along with that, there is extensive fibrosis also, which you can see. Though the amount of fibrosis may vary, and that is not that it occurs in one particular location. It can occur anywhere and in the breast. It is frequent incidental finding in the breast specimen. Maybe the breast is there is lumpectomy or the mastectomy done for any other causes, and you find the sclerosing adenosis. And this has wide age group, around like third to fourth decade is the common one. And characterized by enlarged lobular units to the proliferation of the small acinar tubular structures. They are compressed or distorted by the stromal collagen. So ductules are smaller, somewhat irregular, and I'll show you the picture of this. They have associated risk of developing subsequent cancer, which is around 1.5 to 2. That is like for the other proliferative benign breast lesions. So there will be I can show this with the pictures. So you can see there is a lobulocentric proliferation of the ductules and the glands, and they both the layers will be present in this. So this is the epithelial layer, and around them will be the myepithelial layer. And in these cells, you can see there's been distinct basement membrane also. And along with that, there is stromal fibrosis, which is causing distortion of these tubules, proliferating tubules also. And actually, recent WHO classification, WHO has given few essential and desirable criteria for most of the tumors, both in benign and malignant tumors, including adenosis. So, in most of these cases, I would be talking about these criteria, and I'll hopefully reduce repetition. So the essential criteria, as I told, along with these, they retain all these things we have spoken already, and there is also retained myepithelial layer around the acinar and tubular structure. So, and the desirable criteria, that is the IHC for the further identification of myepithelial cells. So initially we spoke about so many markers for the myepithelial cells. So we can use that. So they have recommended P53, calpain, smooth muscle mycin, heavy chain. And the next type of adenosis is the apocrine adenosis, and simultaneously we also talk about apocrine adenoma. So apocrine adenosis, you call it as apocrine adenosis when there is apocrine metaplasia in the sclerosing adenosis. That is also the rest of the features are similar to the sclerosing adenosis, and the lining in the epithelial lining they show apocrine changes. And apocrine adenoma, on the other hand, it is well delineated benign tumor. So it has dense diffuse proliferation of round oval tubular structures. They are composed of large epithelial cells with abundant neoplasm, that is the apocrine change. So it can, both of these arise in the TDLUs only. So adenosis is often incidental. They may have microcalcification. So in those cases, on MRI or mammography, they give it as non-mass-like enhancement. So mostly third to fourth decade, grossly nothing much significant. And on histopathology, I told you it is like the sclerosing adenosis with apocrine change. And they are mostly positive for the androgen receptors, though they are negative for the ER. They are also positive for CK8, CD10, GCDFB15, and the cyst fluid expressed in this can also be examined. They are positive for GCDFB15, 24, and 44. So apocrine adenosis, I said that is common, but on the other hand, adenoma is extremely rare. So I told you they are appearing as a nodule. So mostly solitary, painless, freely mobile nodule. Well circumscribed, and so I have told you already. So they may the glands may be cystically dilated or may have delicate papillary fronds. And cytology also, you can see cytology in adenosis will be very cellular smears, cohesive clusters, and epithelial will be showing apocrine metaplasia. So, and one more thing is in the apocrine cells, there may be supranuclear vacuoles which may contain iron. So they have slightly this thing apocrine adenosis, atypical ones. They have slightly increased variation in the nucleoli. So they can be 2 to 3 fold variation often in the prominent nucleoli. And there also is the essential and the desirable criteria for apocrine adenosis, the same things which we have already discussed. And in the desirable criteria, they are PS positive, diastase resistant, as we all know. They also express the markers which we just spoke, EMA, CK8, 18, AR, and for both adenosis and adenoma. And subsequent breast cancer risk associated with the diagnosis of adenosis is 1 to 2 fold. So this is just a picture of adenosis showing apocrine change. Gland showing apocrine change. So we can see they have abundant eosinophilic cytoplasm, and they have apocrine snouts here. And there will be some variation in the nuclear pleomorphism. Tubular adenosis is just for formation of ductules arranged so that if they are cut longitudinally, they can be seen. Just proliferation, they are not lobulocentric, but they have clear basement membrane and the myopithelial cell is not there. So sometimes these are confused with the carcinomas. So they have haphazard proliferation of small round glands consisting of single layer of epithelial cells without accompanying myopithelial cell. This is what I said. And they do not have characteristic gross appearance, range mostly 3 to 4 centimeter, but they can be very huge, large. And these are not lobulocentric. Glands are uniform, small in size, slightly larger than the normal lobular acini. And there can be clustering of the glands at times and lobule-like aggregates. So main thing you have to know is the loss of the myopithelial layer. So this is where they'll be having a small round glands, and they are lined by either flat to cuboidal epithelial cells. There will be loss of myopithelial cells. You can see all these are single layer. There are no myopithelial cell layer. But however, they'll have basement membrane. So you can use PAS stain also to highlight the basement membrane, or you can use the IHCs to highlight the basement membrane. So, and the secretions inside inspissated secretion, they are also positive for PS, they are diastasis resistant and mucicarbon positive. And most of the adenosis you may find in the specimen which is taken out for something else. So I also got most of the pictures of adenosis being taken from the specimen which were diagnosed as Fibroadenoma or something which came for IDC. And the one which I showed as florid adenosis, it actually came as malignancy. So ultimately on histopathology, it was showing florid adenosis. And even this one, microglandular adenosis, also has these criteria. So essential criteria is same, haphazard proliferation, small round uniform glands. Adipose tissue and best parenchyma, both of them will be infiltrated, but they do not destroy the pre-existing normal glands. And they have single layer of cuboidal cells. They don't have atypia. You can use IHC. They typically express cytokeratins, S100, cathepsin D, EGFR or HER1 overexpression of HER2. They are negative for EMA, ER, and PR. So this is also one of the picture. The same thing you can see. They are monolayered and they have distinct basement membrane. Next, coming to the columnar cell lesion. So they are the clonal alterations of the TDLU, characterized by enlarged, variably dilated acini, lined by columnar epithelial cells. So on mammography, they are detected by amorphous calcifications only. And earliest, these are actually the evidence suggests that the earliest stage, they are the earliest stage in the low-grade breast neoplasia pathway. They represent non-obligate precursors for ADH, low-grade DCIS, low-grade invasive carcinomas, including tubular carcinomas. And here we can see in this picture that they have dilated, enlarged, acini, variable size, and they all are lined by the columnar epithelial cells. They have irregular contour, and they will not have atypia usually. So in this closer look, we can see that all these cells, they are columnar in shape, and the elongated oval nuclei which are arranged perpendicular to the basement membrane. So columnar cell change, we call it when there is like only 1 to 2 cell layer thick. If it is more than 2 cell layer thick, if there is cellular stratification, tufting, so we call it a columnar cell hyperplasia. Usually they do not have cytological atypia. So when there is cytological atypia, what do there will be flat epithelial atypia along with them, along with CCL. So this is flat epithelial atypia is characterized by low-grade cytological atypia. It is a lesion of TDLU. and they are precursor to ADH and low-grade DCIS. And also there's genetic overlap between the CCL, and the CCL is columnar cell lesion, and flat epithelial hyperplasia, atypia, and the advanced lesions. That epithelial atypia is characterized by replacement of endothelial cells of TW by one of the several layers of multiple cuboidal to columnar cells. They often have apical nodes. Occasional tufts and mounds may be seen. There is absence of well-developed arcades, bridges, micropapillary configurations. Acini of involved TDLUs show variably dilated, have smooth contours, and contain secretions or flocking material, often with microcalcification. The nuclei of the neoplastic cell, they tend to be uniform and have inconspicuous nuclei. Like lymphoid infiltrate may be present in the interlobular stroma. So, for both columnar lesion and flat epithelial atypia, the cells are consistently demonstrate strong and diffuse nuclear staining for ER. They lack staining for high molecular weight cytokeratin like C4 and changes in the breast, and they have strong association with the lobular neoplasia. Either it can be in situ carcinoma or atypical lobular hyperplasia. And all these ADH, low-grade DCIS, low-grade invasive cancers, they are more frequent. If FE or the flat epithelial atypia is more frequently associated with them. So these are the differences which we had just discussed. And for the drainage only, this is from the essential criteria for them. And few studies also show that the columnar cell change and hyperplasia are associated with slight increased risk for the subsequent development of breast cancer. And flat epithelial atypia may progress to invasive breast carcinoma, though the risk of progression appears to be very low. And there is substantial overlap features with the papillary neoplasm and well-differentiated adenocarcinoma. So they are difficult to identify and cytology. So coming to the next entities, adenomyopithelioma. So this is a biphasic neoplasm of the breast, and it has its counterpartum in the salivary gland also. So and when somebody asks biphasic lesions in the breast, mostly the trainings would be talking about the fibroadenoma and adenomyopithelioma also come under biphasic neoplasms of the breast. So they are usually benign, though they have malignant counterparts. So these are characterized by small epithelium-lined spaces, inner luminal ductal cells, proliferation of variable, enlarged and clearly noticeable abluminal myopithelial cells. Malignant transformation may occur. It can either occur from the luminal cells or from the myopithelial cells. They can arise anywhere in the breast. It can appear retroareal or also anywhere in the breast parenchyma also. And nipple discharge occur when the large lactiferous ducts are involved. So they are seen mostly in the elderly female, more than 60 years. They have a palpable nodule. Rare genetic association is seen with the syndromes, genetic syndrome, like neurofibromatosis type 1. They are actually the genetic drivers, they categorize according to the ER status. ER can be either positive or negative in them. So the AKT1 hotspot mutation that is mostly seen in the ER positive cases. And this AKT1 hotspot mutation associated adenomyopithelioma, they are more highly recurrent. And the other one is the HRAS hotspot mutations. They are mostly seen in the ER negative adenomyopitheliomas. They are more frequently found in the salivary and malignant counterparts. And the last one is the PIK3CA hotspot mutation, which can occur either in positive or negative adenomyopithelioma. So I'll show you with the pictures. So they can show multiple lobulated appearance. Tubular structures or the papillary structures which can appear, and you'll be having abundant myoepithelial layers also with them. So all these ones lying in the epithelials. it can also show squamous metaplasia and also sebaceous cells. You can find all this in same slide also or in the different slides also. And when they are involving the papillary ducts, a lot of the time the intraductal papilloma is one of the DDs for them. So you can see there is tubular structures which are lined by the epithelial cells and the paler cells which are surrounding them. So those are the myoepithelial cells. And here also all these cells which you are seeing in the background of the cells. These are the myoepithelial cells. At times, myoepithelial cells will be so normal, it is difficult for you to find the epithelial cells in them. So that is also possible. So this was initially thought to be papillary neoplasm. Later on, with a closer look and more sections, we could make it as adenoma epithelioma. And this is a IC which we have put up, that is a SMA to highlight the myoepithelial. Nicely highlighting the myoepithelial cells. So essential criteria is the same thing which we just studied. After this we come to the fibroepithelial neoplasm. So fibroepithelial neoplasms, these are they are both the fibroadenoma and fibrous tumor, as you all know. So they are biphasic neoplasms that exhibit proliferation of both epithelial and stromal component. Stromal component is the mesenchymal component. So in Phyllodes tumor, usually they occur like 50 to 20 years later than the fibroadenomas. And MED12 mutations are frequently found in all types of fibroepithelial tumors. With this MED12 mutation pathway, it is likely to be involved in the progression of fibroadenoma to Phyllodes tumor. This is what it says, and they are somatic mutations. So you see them mostly in the stromal cells. And malignant Phyllodes tumors have a low rate of MED12 mutations than the benign borderline. So if they are of de novo origin, you don't find these MED12 mutations in the malignant Phyllodes. So if you find these MED12 mutations, they say this is progressed from fibroadenoma to Phyllodes. Circumscribed fibrocystic epithelial and stromal components. This is the most common breast tumor in adolescent and young women. They arise from the TDLU epithelium and stroma. They are hormonal sensitive, and they actually increase during pregnancy. They have sensitivity to estrogen. So on mammography, they are seen as rounded lobulated masses. So this is macroscopic or gross picture of fibroadenoma which I've taken from. So they are usually circumscribed nodules with pushing margins. They are sharply demarcated. Usually, if you look at the specimen, they are sharply demarcated from the surrounding area, and they'll be appearing as firm bulging tumor. They'll be having lobulated, solid and rubbery. That is what the consistency we talk about when we talk about fibroadenoma, even when you're evaluating the patient for FNA. And they have gray-white cut surface. It may be lobulated or whirling, and you can see slit-like spaces in them. Usually, size would be like 2 to 3 centimeter. If they are more than 5 centimeter, we call them as giant fibroadenomas. So, in the same case, you may find one single fibroadenoma also. You can find multiple also, which may be metachronous, synchronous. And mostly patient present with painless, solitary, firm, slow-growing, mobile, well-defined nodules. Mostly they would be around 2-3 centimeter or lesser than that. More than 5 or giant fibroadenomas are usually uncommon. So since they are hormone sensitive, they tend to grow rapidly during pregnancy. So they are well circumscribed with pushing margins. There will be two types of patterns which we can see on microscopy. One is intracanalicular, the other one is pericanalicular. So I'll explain this with the pictures. So this is the photomicrograph where you can see this is a circumscribed lesion, and you can see various ducts being compressed. So intracanalicular pattern is where the stroma, surrounding stroma is compressing the ducts. And we call it as pericanalicular when the stroma is surrounding the open ducts. So here it is compressing when it is intracanalicular. In pericanalicular, we call when the ducts are opened up and the stroma is just surrounding them. And you can find both patterns in one case also. And mostly they are bilinear, and they can be seen along with the other proliferative lesions like as I told, adenosis, and they can be ADH, DCAS, tubular neoplasia, fibrocystic change, squamous apocrine metaplasia. All these can be seen along with the fibroadenoma. So in fibroadenoma, what happens is proliferation of the specialized stroma, that is the neoplastic component around the pre-existing glands. So there are a few things we'll have to assess in the fibroadenoma to differentiate that from the phyllodes. So one of them is the stroma cellularity. And focally, we can also find phyllodes like features with the fronts. They'll focal or diffuse stroma hypocellularity can also be seen multinucleation, and some metaplasia can also be seen in the stroma like Conrad or Shears and all. And mixed white chains can be seen. Spontaneous infarction can also be seen in pregnancy because it's rapidly growing to undergo spontaneous infarction also in pregnancy and lactation. So one of our seniors used to always say, so assess all these 6 features in the fibroadenoma. A, B, C, S, M, M. That is what he will teach us as. So in fibroadenoma, there will be no atypia. So atypia, where will you look for atypia? Not in the epithelium, but in the stroma. So that is just stroma. So there will be no small atypia. That will not be seen in the fibroadenoma, which is seen in the phyllodes. Mitosis is absent, and you don't see any malignant heterologous elements in fibroadenoma. And there are actually types of fibroadenoma which we can see. One of them is juvenile fibroadenoma, more commonly in adolescents, but though it is not restricted to the adolescents. They actually cause breast distortion, and they can also rapidly grow to form giant adenomas. So in this, mostly they can they have mild to moderate increase in stromal cellularity. Fascicular stromal arrangement will be seen. As I said, rapid growth may be seen, which way they will be forming giant fibroadenoma. And usually is less than 1 per mm square or less than 2 per 10 hyperfill. Usually, the previous WHO always mentioned less per 10 hyperfill. So now they have also given in terms of millimeter square. So depending on your microscopes, you can adjust this. So stroma is less than 1 mm square, 1 per mm square, or less than 2 per 10 hyperfill. And complex. So they 3 mm closing adenosis,
Pavithra,
or if the
screen is not changing. Just a minute. Your screen is not changing. I mean, we are only seeing the fibroadenoma screen.
Okay, sir. One second. I'll try to reconnect.
Yeah, now it is changing. Now it has changed. Can you just go back one screen backward, please? Hello? Hello? Can you hear me?
Visible now?
Yeah, I mean, can you hear me?
Hello.
I can't hear you.
Yes, sir.
Hello, I can't hear you. Yeah, your voice is breaking, actually. Just can't hear you. Just check the internet connection at your end, please.
Sir, is it better now? Am I
Yeah, now I
audible?
think, yeah, your voice is audible now, but yeah, please go to the full screen. Yeah, please go to the full screen. Yeah,
Okay.
yeah,
Possible now,
fine. Just,
sir?
yeah, very visible. Now change the
Sir,
screen, please. Just change the
where
screen.
should I start
Yeah,
from? Is it
I
moving?
think you start from fibroadenoma. Yeah,
Okay.
yeah,
From the beginning, sir.
yeah, from the beginning, please, if you don't, because it's not changing. I mean,
Okay.
we thought it
Okay,
will come.
sir.
Yeah, yeah, but right from here,
From
right
here,
from.
sir.
Yeah, fine, fine, from here. Yeah,
Okay, sir. So, am
is
I
it
clear
okay?
now, sir?
Yeah, you're clear. I mean, sometimes it's just going away when you're speaking a bit fast, then your sound just disappears. Otherwise, it's
Okay.
fine. It's it?
Okay, sir.
Okay, okay. Please, please. Thank you. Bye bye.
Uh,
Carry on,
Sorry.
please.
Okay. So, fibroadenoma is another benign biphasic proliferation of the sorry. Fibroadenoma is another biphasic benign entity which is showing biphasic proliferation of the epithelial and stromal cells. So they are usually circumscribed and mostly commonly they are seen in the adolescent and young women. They arise from the epithelium as well as the stroma of the TDLUs. So they are usually hormone sensitive. They increase during pregnancy and involute during menopause. So that is because they are hormone sensitive. And mammography, they you appear as rounded lobulated masses. So this is a gross picture which I've taken from a book. See, they are usually appear as circumscribed nodule with pushing margins. They are usually sharply demarcated from the surroundings, and they'll be having bulging tumor. They have lobulated the consistency which we call as rubbery. Even when you examine the patient of FNA, the consistency which they mention is rubbery in fibroadenoma, and they have gray-white cut surface. The cut surface will be gray-white. They can show whirling and slit-like spaces. Usually they are 2 to 3 centimeters, and if they are more than 5 centimeters, they are called as giant fibroadenomas. Oh, there can be multiple fibroadenomas in the same or opposite breast, which can be synchronous or metachronous. Usually present as painless, solitary, firm, slow-growing, mobile, well-defined nodules. Mostly they'll be around 2 to 3 centimeters, not more than that. So if they are more than 5 centimeters, we call them as giant fibroadenomas, which are more than 5 centimeters. And they are usually, I'll show you with the pictures, the patterns. This picture photomicrograph shows a well circumscribed lesion with the proliferation of the epithelial and stromal component. The below picture, this shows compression of the ducts by the stromal cells, stromal cells. So that is known as the intracanalicular pattern. If the surrounding stroma is not compressing the ducts, but they are surrounding the open ducts, that is known as pericanalicular pattern. So you can see this pericanalicular pattern in the juvenile fibroadenomas also, and both pattern can be seen in the same lesion also. And they are usually associated with the other proliferative lesions like adenosis, ADH, DCIS, lobular neoplasia, fibrocystic change, squamous and apocrine metaplasia of the epithelium. Uh, they are things like they can be proliferation. This is a proliferation of specialized stroma, that is the neoplastic component around the pre-existing glands. So you'll have to assess the cellularity to differentiate with the Phyllodes tumor. So cellularity is one of the components. Focal Phyllodes-like features can also be seen, and they can be focal stromal hypercellularity, bizarre multinucleated cells. So these can be seen, so that it does not indicate that it is malignant. And you can find some metaplasia also. Along with that, there can be myxoid change, and in pregnancy or lactation, they can undergo spontaneous infarctions. So, one of our seniors used to say, we have to assess all these features in fibroadenoma and phyllodes to differentiate between fibroadenoma phyllodes and also between the phyllodes. So, this WHO features, but he used to always give us a mnemonic ABCSML. So A is for atypia. Atypia, you look for atypia in stromal cells, but not in the epithelial. So stromal atypia will not be there in fibroadenoma. Borders will be well defined. C is cellularity. You look for stromal cellularity, which are uniform. Sometimes they can be variable, but they will not generally be hypercellular. and stromal overgrowth will be absent. Mitosis absent, and malignant heterologous elements will be absent. And to come to the types or variants of fibroadenoma, there is juvenile fibroadenoma, which is seen mostly in the adolescents, but it is not restricted to adolescents, but commonly seen in adolescents. They can actually grow rapidly in size, and they can form the giant fibroadenomas also, causing the breast distortion. And they mostly have pericanalicular pattern. They have mild to moderate increase in stromal cellularity, fascicular stromal arrangement. Mitosis usually less than 1 per mm square or less than 2 per 10 IPA field. You can either take in mm square or per 10 IPA field. And the next entity is the complex fibroadenoma. They have, it is like one or more of the following features are there. You call them as complex fibroadenoma. So that is like cyst more than 3 mm, sclerosing adenosis, epithelial calcifications, papillary apocrine metaplasia. So they are present in 3 to 4% of the benign breast biopsies and 16 to 23% of all fibroadenomas. These carry slight increase in the relative risk of malignancy, that is like 2.2 to 3.1 times the general population. And next is the myxoid fibroadenoma. So they usually show extensive myxoid change in the stroma. They can present as gelatinous nodule. So they can be mistaken for mucinous or colloid carcinoma on the needle core biopsy. So you should be very careful when you get such needle core biopsies. Because they also can have bizarre multinucleated giant cells. So though they don't have any prognostic significance in the myxoid fibroadenoma, we should be careful not to call it as mucinous carcinoma. They are commonly associated with recurrence in patients younger than 40 years of age, and syndromic association can be seen with Carnes syndrome. So this is cytology from FNA of one of our patients of fibroadenoma. So what you can see, usually the smears of FNA would be very cellular, and they'll be having antler or staghorn shaped epithelial clusters. So they'll be having deep lobations like this one, epithelial clusters will be seen. And background you can see bipolar nuclei. They give an appearance of sesame seeds among the epithelial fragments. So all these the single nucleated cells you can see, they are usually the bipolar cells or bad nuclei which you can see. And epithelial clusters, they often have admixed myopithelial cells with them, which you can see as dense nucleated cells. And stromal component, stroma can also be seen in the background with myxoid material. So again, the essential criteria given by WHO. So circumscribed intracanaliculaire pericanaliculaire pattern, no stromal overgrowth, absence of well-developed fronts, no stromal atypia, low mitotic activity in stromal cells. Risk of malignancy is 1.5 to 2-fold. And next, coming to the last entity, that is the Phyllodes tumor in the fibroepithelial tumors. So this is generally circumscribed fibroepithelial neoplasm showing intracanalicular. Mostly the Phyllodes tumor shows intracanalicular architecture with leaf-like stromal fronts. They are capped by luminal and myoepithelial cell layers, and they are accompanied by stromal hypercellularity. They can arise in any part of the breast, including the ectopic breast tissue. Usually they are unilateral. They also present as painless mobile masses, usually around 4 to 5 centimeters, slightly larger than the size of the fibroadenoma. Axillary lymphadenopathy can be seen, not necessarily due to metastasis. They can be as a reaction to the tumor necrosis or infection. So axillary lymphadenopathy due to Phyllodes metastasis is very, very rare. And Phyllodes tumor on ultrasound or mammography, they are rounded, bosselated, circumscribed masses with clefts or cyst, and coarse calcification can be seen. So they are actually patient present with a history of rapid growth in the size in a short period, and even if they have been excised earlier, there may be a history of local recurrence. And malignant phyllodes can also metastasize. Usually, I said nodal metastasis is very rare axillary lymph node. they can have distant metastasis, which is also very rare. Around 2% cases are reported to lungs and all. And they predominantly occur in the older women. Average age is 40 to 50 years, though there is no age restriction. And origin is from the intralobular periductal stroma, and stromal epithelial interactions will be seen. So during malignant progression, the stroma becomes independent of the epithelial reaction, and there will be autonomous stromal overgrowth. So there will be overexpression of TP53, c-KIT, and EGFR with genetic aberrations in malignant ones. And also fibroadenoma-like areas can also be seen in phyllodes. So sometimes I have seen JAs asking, we have areas of fibroadenomas, we have areas of phyllodes. So should we call it as fibroadenoma with phyllodes? So there's no point calling like that, because once you have phyllodes, there is no point in telling this has fibroadenoma with phyllodes in the report. Okay, and on gross, they usually appear as bulging masses, and mostly they are unilateral, firm, painless. They usually don't attach to the skin, though there is stretching of the skin because of the huge mass which is enlarging, and they usually have clear defined margins. Homogeneous walled appearance will be there. Hemorrhage, necrosis, calcification, you may or may not see, depending on the specimen and the size. So this is a panel of photomicrographs which is showing the pericanalicle. The duct is elongated, enlarged, and hypoplasic. This is also compressed by the stromal overgrowth. So we see for stromal overgrowth in the periductal region mainly. The periductal stromal overgrowth is seen, and this was a case which we had reported as borderline. So this is one of the mitotic figures which we had seen, though there is no atypia. Usually in the malignant we see lots of atypia. In benign and borderline, we may not see so much of stromal atypia. Here also atypia means that is stromal atypia, not the epithelial ones which we look for. And the stromal cellularity may be variable in the entire specimen. So phyllodes can be divided as benign, borderline, and malignant. So the same features: atypia, A atypia, B border, C cellularity, S stromal overgrowth, M mitosis, and then M malignant heterologous elements. Along with the relative proportion, how common they are. So atypia, you look for stromal atypia, which is mild or none in benign, mild or moderate, mild to moderate in borderline, and it is usually marked in malignant phyllodes tumor. Borders are mostly well defined in benign. They may be focally permeative in borderline, but here also they are mostly well defined. In malignant, you will find some or the other permeative borders. Cellularity, usually all these are cellular compared to that of fibroadenoma, but usually mildly cellular in benign, and moderately cellular in borderline, and very cellularity will be marked or diffused in the malignant one, malignant phyllodes. And stromal overgrowth will be seen in the malignant phyllodes. Benign can show very focal stromal overgrowth. It is not seen in benign. Mitosis usually low, frequent, and abundant. Low, less than 2.5 per mm square or less than 5 per 10 hypafilled in benign. 2.5 to less than 5 per mm square, 5 to 9 per 10 hypafilled. Either of them will work for borderline. And more than 5 or equal to 5 per mm square or 10 or more per 10 hypafilled in malignant. So malignant heterologous elements you get mostly in, you get only in malignant phyllodes. Relative proportions in all the phyllodes tumor, benign is the most common one, forming 60 to 75% cases. Borderline is seen in 15 to 20% cases, and malignant in 10 to 20% cases. So after all this, the last entity of the today's discussion is breast diseases in males. So male breast can have any lesion which can occur in female breast. So there are a few which are seen commonly, like gynecomastia, PASH, mastitis, diabetic mastopathy or lymphocytic mastopathy, myofibroblastoma. Some malignancies which occur in female breast can also occur, and other miscellaneous lesions like mammary duct ectasia, sclerosing adenosis, fibroadenoma, all those things can occur. So let's discuss about gynecomastia. So gynecomastia is enlargement of the male breast resulting from hypertrophy, hyperplasia. So there is both hypertrophy as well as hyperplasia of both glandular and stromal components. And etiologically, there is relative increase in the estrogen activity. Estrogen can be either endogenous or exogenous. Decrease in the androgenic activity or both of these. So most cases, patient will not have any relevant history. So those are idiopathic. So if they occur before 25 years of age, usually due to the hormonal pubertal changes, and in the later ages, that may be due to some hormonally active, some tumors or cirrhosis, or if the patient on medication, especially like spironolactones and all, spironolactones, they can cause gynecomastia. So clinically, mostly these are seen behind the nipple. So it can be either unilateral or bilateral. Left side is more common than right side in unilateral ones. And on mammography, they are seen as round retroareolar density with stranded extension into the deep adipose tissue. Grossly, they can appear like oval, disc-shaped mass, elastic consistency, usually well circumscribed borders. So, on microscopy, there will be variable degree of epithelial hyperplasia. They are surrounded as stroma. Mostly, the stroma immediate adjacent to the epithelium, they will be showing a myxoid change. Mostly that is the stroma contains acidic mucopolysaccharides like hyaluronic acid, and some short duration cases they have prominent hyperplastic epithelial component, often with micropapillary architecture stromal edema. Otherwise, long durations ones may have stromal fibrosis. That is all. Thank you.
Thank you, Dr. Pavithra. Very nice presentation of a very long and extensive benign lesions of breast and the fibro-epithelial lesions. Now let us wait to see if there are any queries and questions from the people in the Google Meet. And then otherwise we will go to the YouTube questions if there are any. There is one question which was asked by Dr. Manaza. Would you like to take that question? The question is, can you hear me, Dr. Pavithra?
Yes, sir.
The question is how to differentiate between microglandular adenosis and tubular carcinoma.
So, tubular carcinoma is entirely, this is a thing which we'll be discussing in the next class actually. Okay. On next Wednesday when we talk about the other malignancies. So, I think I'll be discussing with them.
Okay, fine. So I think that time we will, talk about the differentiation between microglandular adenosis and tubular carcinomas, right?
Yes, sir.
Yeah. Is there any other question from anybody in the Google Meet? There are none, and there are no questions also.
I send you 3 questions.
Have you sent any question here? Have you typed any question here?
I have sent you 3 questions. One question is there test? You have not received that?
I can't see your questions in the chat box.
Okay. One question is that whether infarction is possible in the case of the fibroadenoma.
Okay. In case of fibroadenoma, do we get infarction? Yes, we do get some infarction.
Yes, sir.
Yeah.
Yeah. Next question, sir. Yes, Dr. Pranab.
Okay. Okay. Chat box. Where is the chat box? Yes.
Yeah. What is the next question?
Sorry, it's okay.
Okay. Fine. Since there are no more questions, thank you, Dr. Pavithra. Wonderful presentation. Very nicely done. Thank you so much. Thank you everybody for joining in. Right. See you then again. I think next Wednesday. Is that right?
Yes, sir. And thank you so much for letting me speak, sir. Thank you so
Oh,
much.
my pleasure. The pleasure is
Thank
mine.
you. And I would thank all my teachers who have taught me so much.
Thank you so much. Okay, then. God bless everybody. Take care. Bye bye. Good night.
Good night.